How many operative performance ratings does a pediatric surgery fellow need to be deemed practice ready? This will be presented by Dr. Brianna Spencer.
Good morning. Thank you for the opportunity to present our work. I have nothing to disclose. Surgical training is currently time-based rather than competency-based. With duty hour restrictions, it's unclear if our residents are truly reaching competence at the completion of residency. The Society for Improving Medical Professional Learning, or SIMPLE Evaluation app, has allowed for real-time assessment and evaluation of trainees in the operating room and has been widely implemented in general surgery residencies. The SIMPLE app is also beginning to be utilized in pediatric surgery fellowships. While in general surgery, research has been done to better understand the number of operative performance evaluations needed to assess competency, this concept has eluded educators in pediatric surgery. From our previous research with general surgery residents, we were able to identify when a resident had a 95% chance of earning a practice-ready rating on a subsequent procedure. In this study, a similar approach was applied to pediatric surgery fellows to better understand a fellow's likelihood of performing at a practice-ready level for a given procedure with 95% probability. We hypothesized that a similar modeling approach could be used to determine practice readiness of a pediatric surgery fellow for a select number of procedures. Data were collected using the SIMPLE app, an online survey platform. The SIMPLE app allows for an attending surgeon to rate a fellow on their autonomy and performance, as well as record overall complexity of the case. Performance can be rated as underprepared, critical deficiency, inexperienced, practice-ready, or exceptional. In this study, we recorded performance scale whereby practice-ready and exceptional were considered practice-ready, and all other response options were considered not practice-ready. We compared data from 2 academic pediatric surgery fellowship programs. We directed our focus to include procedures with an adequate sample of more than 40 observations. We focused our comparisons between sites for 3 procedures: laparoscopic inguinal hernia repair, laparoscopic gastrostomy tube placement, and laparoscopic pyloromyotomy. We used a Bayesian generalized linear mixed effects model to estimate the relationship between the number of practice-ready ratings that a trainee has earned for a given procedure and their 95% likelihood of earning a practice-ready rating the next time they're rated on that procedure. Site 1 had 26 attendings and 9 fellows evaluated, with a mean of 42 ratings per attending and 121 ratings per fellow. This yielded a total of 1,094 ratings, of which 71% were practice-ready. Site 2 had 25 attendings and 3 fellows evaluated with a mean of 9.4 ratings per attending and 78 ratings per fellow. This yielded a total of 234 ratings, of which 65% were practice-ready ratings. As can be seen here, the shapes of the predicted performance curves between the 2 sites were quite similar. Site 1 had less variation around the mean predicted value as represented by the black line, due in part to the larger sample size of this group. Across both sites, there were similar performance expectations for laparoscopic gastrostomy tube placement. 13 practice-ready ratings were required for Site 1, and 14 practice-ready ratings were required for Site 2. Note that these are practice-ready ratings and not just general ratings per procedure. A slightly greater difference is seen between the 2 institutions for laparoscopic inguinal hernia repair, where Site 1 only required 10 ratings and Site 2 required 15 ratings. This was similar for laparoscopic pyloromyotomy. Site 1 only required 10 ratings and Site 2 required 15 practice-ready ratings per procedure. This study demonstrates a feasible approach for collecting operative performance data and thereby can aid in case requirements and data-driven standard for fellows. For the procedures studied, we found that fellows required 10 to 15 practice-ready ratings to achieve a 95% probability of a practice-ready rating at the next procedure. Future studies include expanding this analysis to additional procedures unique to pediatric surgery across multiple institutions and including these data to better understand case requirements in pediatric surgery fellowship as we move toward competency-based rather than time-based training. Thank you, and I'm happy to take any questions.
Open for questions.
Greer Arthur, St. Peter's University Hospital. Great talk, interesting proposal. Two questions. One, how do you see this bearing out if we abandon the time period? Like, do you have any ideas of how we would, do that? Just continue fellowships for 3-4 years, so on. And then, how would you approach this with the more rare cases, the anorectal malformations, TEFs, things of that nature? Do you have to do 15 of those rated? Thank you.
Thank you for your question. In regards to transitioning to competency-based rather than time-based, looking at this as more of a way to predict fellows who might be struggling, who aren't following along the curve as other fellows, as an opportunity for intervention. So in that way, you could recognize a fellow that's halfway through their fellowship and not reaching that practice-ready curve as their other fellows. And then for rarer cases, we had discussed this as a group as potentially grouping certain cases that are similar together in order to better understand that cohort when we don't see as many of those.
Are you using the simple application for all of your cases, not just the ones that you described here?
Yes, at both institutions, the simple app's being used for all the cases.
Thank you for the talk, Polygamla Montreal. I think it's a great, it's really, really important as we make the transition to competency-based education. I was just curious from a process issue, how long does it take for an attending to actually complete the assessment? Because one of the big stumbling blocks with rapid assessment is making it easier for the evaluator. And if the evaluator feels encumbered because they have to do a lot of work in order to do that assessment will not get done. So just curious about that. Thank you, great talk.
Thank you for your question. As far as I understand, the ratings move pretty quickly. They've been rolled out in our institutions without much difficulty and good buy-in from the attendings, but that is something to consider with these evaluative measures, the time that it takes to put in that work.
Hi, great talk. Alan Ladd from Indianapolis. I thank you for the opportunity to show us how we can use our technology to see how we can advocate for training of our fellows. But I wonder if you could tell us, if your data alluded to, how many cases does it take to routinely get to that practice-ready level of performance?
Thank you for your question. We did look at that information, and it ranged between at least 20 to 30 cases, although it was quite varied among the fellows.
Thank you.
Thank you.